In the short time since the discovery of the sulfonamides and then penicillin, the world has witnessed greater progress in the control of infectious diseases in man and animals than has previously occurred in medical history. The scene is changing with such rapidity that what is known today is frequently invalid tomorrow. The practitioner must ever keep abreast of late clinical evidence in order to exercise sound judgment in employing antimicrobial agents available to him. It is the purpose of this film, therefore, to say in effect, this we know, but there is more to learn. Since the introduction of broad-spectrum antibiotics, the dramatic changes in morbidity and mortality statistics have established antimicrobial agents as one of the major avenues of attack against infectious diseases. Tetracycline, dimethylchlortetracycline, chlortetracycline, oxytetracycline, chloranthenical, streptomycin, the sulfonamides, or penicillin have been shown to be effective in the control of brucellosis, pertussis, Rocky Mountain spotted fever, scarlet fever, tuberculosis, tularemia, typhoid and paratyphoid fever, and typhus. But valuable as antibiotics are, they cannot replace accurate diagnosis, therapeutic judgment, and skilled surgery. Infections must be properly treated and anatomic abnormalities corrected. Even though many infectious diseases may be controlled by antimicrobial agents, many others will either not respond to them or are of such nature that it is desirable to prevent their occurrence by immunization. Passive immunization against these diseases may be of value in decreasing the severity of the symptoms. Combined immunization against diphtheria, pertussis, and tetanus should be started at 1 to 2 months of age. Polio vaccine may be started at the same time as the other immunizations. The initial course should consist of 3 injections of triple antigen given at intervals of not less than 1 month and preferably not more than 3 months. It is recommended that a 4th injection be given a year following the 3rd injection. Injections should consist of 0.5 ml made into either the deltoid or the gluteus maximus muscles. Injections should not be made more than once at the same site during the primary course of immunization. Those states having the largest number of diphtheria cases are shown in the darkest color. Reported cases of diphtheria, as might be expected, have shown a steady decrease during the last 15 years. Diphtheria infection sources are discharges and secretions from the surfaces of the nose, throat, nasopharynx, skin, and other lesions of infected persons. A diagnostic test consists of culture rapid growth of bacteria in 4 hours on horse serum impregnated cotton swab kept at 37 degrees centigrade in Leffler's or tellurite media. Strains isolated should be tested for virulence. For older children and adults, diphtheria toxoid as a single antigen is indicated in reduced dosage for primary immunization and booster injections. In primary immunization of children in the preschool age, the use of diphtheria toxoid alone is recommended only when there is some specific contraindication to the use of the triple antigens. For individuals over 10 years old, diphtheria toxoid in doses exceeding 200ths to 500ths ml should not be given without a preliminary Schick test together with a Maloney or Zella toxoid sensitivity test as a control. For primary immunization of children less than 10 years of age, give 3 intramuscular injections of 0.5 ml at intervals of at least 1 month, but preferably not more than 4 months. For individuals more than 10 years of age who are Schick-positive reactors with negative sensitivity tests, the primary immunization course is the same as for children under 10. Individuals showing positive reactions to both the Schick test and a toxoid sensitivity test should not be given for the toxoid. Negative reactors to both the Schick and toxoid sensitivity tests require no further toxoid, as the tests themselves serve as small boosters. But if immunization practices, including recall injections at 3-year intervals, are carried out as previously outlined, repeated use of the Schick test to determine individual susceptibility seems unwarranted. Passive immunity may be obtained for about 10 days with diphtheria antitoxin in doses of from 1,000 to 2,000 units intramuscularly. A careful history and adequate sensitivity testing should be done before any animal serum product is administered. However, serum sickness may occur in individuals who had no sensitivity prior to serum administration. Whooping cough sources of infection are from discharges from pharyngeal and bronchial mucous membranes of infected persons. Pertussis vaccine as a single antigen is indicated for attempted rapid primary protection of infants in the presence of epidemics, for primary immunization of children who have been inoculated against diphtheria and tetanus, and for recall injections following exposure. Pertussis vaccine, saline suspended, is useful in attempted rapid protection of exposed individuals during epidemics. A total of 12 NIH units, divided into 3 equal doses, should be injected subcutaneously at intervals of 1 week. Pertussis vaccine, alum precipitated or aluminum phosphate or hydroxide adsorbed, are preferred for infants less than 6 months when there is no need for rapid protection and when he has already received diphtheria and tetanus inoculations or a contraindication to the triple antigen exists. 12 NIH units should be injected intramuscularly in 3 equal doses at intervals of 4 to 6 weeks. Recall injections of 4 NIH units should be given a year later, then in 2 years, and thereafter every 3 years if the danger of whooping cough infection exists. Against tetanus, active immunization is indicated in all children, adults subject to abrasions, and in adults who are exposed to frequent accidents where tetanus spores may contaminate the wound. Primary immunization is obtained by 2 intramuscular injections of 0.5 ml each of alum precipitated or aluminum hydroxide adsorbed tetanus toxoid at an interval of between 1 and 4 months. Recall injections are advised in 1 year and every 5 to 10 years thereafter, or after potential exposure. The effectiveness of emergency boosters is dependent on the time relationship between the injection and the potential development of infection, so that toxoid alone may not be adequate. When the individual already has had previous toxoid, added protection is afforded if, in addition to the booster, he is given hyperimmune gamma globulin in the muscles of a different extremity using the usual precautions. Where the possibility of gas gangrene coexists, a gas gangrene antitoxin is also available. Although smallpox is endemic in various parts of the world, it has virtually been eliminated from the United States. Individuals suspected of smallpox should be isolated strictly pending definite diagnosis. Diagnosis on clinical evidence is generally possible, and preventive measures should be instituted without waiting for results of laboratory tests. Primary vaccination is recommended in the first year of life unless the child is not thriving or is suffering from allergic eczema or dermatologic disorders, with revaccination every 3 years thereafter. The multiple pressure method should be used over the skin of the left deltoid muscle or the posterior aspect of the arm over the triceps muscle. These are the stages of successful primary vaccination. Maculation, 2nd day. Papulation, 4th day. Vesiculation, 6th day. Pustulation, 10th day. Scabbing or crusting, 13th day. Scarring, 20th day. This is an early or immediate reaction. Tuberculin-negative individuals who are potentially exposed to tuberculosis can be immunized with the BCG vaccine. Tuberculin sensitivity is determined by means of the intracutaneous injection of OT or PPD, or by the use of the tuberculin tine test shown here. As soon as possible after completing the tuberculin test, 0.1 ml of material equal to 0.1 ng BCG vaccine should be injected intracutaneously as superficially as possible over the deltoid muscle. BCG vaccine should not be given to infants who are markedly underweight at birth or who are premature, nor should it be given when the person is suffering from infectious diseases. Although the vaccine may be given at the same time with other antigens, it should never be administered simultaneously with smallpox vaccination. Typhoid fever sources of infection are the feces and urine of patients and carriers. Immunization is indicated for residents in rural areas of the United States and Canada where the disease is prevalent. For adults, a total dose of 1 ml standard typhoid vaccine should be given in 2 equal doses, 1 to 4 weeks apart, by the subcutaneous route. Infants less than 1 year of age should receive correspondingly small doses. Sharp febrile reactions are not uncommon. Recall injections of 0.1 ml intracutaneously every 1 to 2 years, depending on probability of exposure. Active immunization against scarlet fever, streptococcal pharyngitis, and erysipelas is no longer attempted since the advent of effective chemotherapy of streptococcal diseases. Adequate treatment of streptococcal infections with one of the penicillins has become most important since the development of acute glomerulonephritis and rheumatic fever may be prevented in this way. Passive immunization has been practiced in the past, but the advent of antibiotics makes the procedure unnecessary. In certain circumstances, it may be desirable to culture exposed individuals and treat those with positive cultures, especially if the index case developed nephritis. Antimicrobial therapy should be seriously considered for administration to hospitalized patients as well as to close contacts of cases. The importance of careful investigation and adequate treatment of any contact having a history of rheumatic fever is well known. Prophylactic use of penicillin and other antimicrobial agents is often necessary. Satisfactory immunity against poliomyelitis has been conferred in several large mass vaccination programs by the administration of 2 feedings of trivalent Sabin vaccine at intervals of 1 to 2 months, or by the feeding of monovalent vaccine at intervals of 1 month. The precise need for boosters has not yet been clearly shown, although recent evidence indicates that it may be prudent to administer booster feedings to children 3 years after the primary series. In the case of measles, passive immunization may be attempted when conditions render it advisable, such as in infants under 12 months, children ill with or closely exposed to other diseases, such as tuberculosis and rheumatic fever. Killed vaccine or gamma globulin is advised for such patients. Passive immunization may be used in institutions to abort epidemics. Clinical experience indicates that 0.02 ml of human gamma globulin per pound of body weight is satisfactory for modification, while 0.1 ml per pound of body weight is considered sufficient for prevention. Passive immunization against or attenuation of infectious hepatitis may be attempted in cases where infection is likely or exposure is known to have occurred. Human gamma globulin, injected subcutaneously or intramuscularly, is thought to give protection for 6 to 8 weeks. Effective dosage range has been found to lie between 0.01 ml and 0.06 ml per pound of body weight. Temporary immunity can be obtained by injection of gamma globulin prepared from donors who have been hyperimmunized with mumps vaccine. Active immunization can be accomplished by means of subcutaneous injections of inactivated vaccines. The recent attenuation of the mumps virus may make routine immunization of infants and children possible. Brucellosis infections in man should be prevented through pasteurization of all dairy products, separation of hogs from milk-producing cattle, and veterinary measures to eliminate brucellosis from cattle and hogs. Active immunization against Rocky Mountain spotted fever is advised only for individuals working in highly endemic areas. Protection from vaccination is not long-lasting. Stimulating doses must be given annually to maintain a high level of protection. 3 subcutaneous injections of 0.5 ml each of inactivated Cox yolk sac vaccine should be given at 5 to 7 day intervals. The case you have seen here is typical of the disease. Active immunization against tularemia is advised only for laboratory workers and those handling wild rabbits and other susceptible animals. Individuals should be skin tested prior to vaccination using 1 to 1,000 dilution of vaccine in saline. Positive reactors should not be immunized as they may develop severe reactions. Negative reactors should be given 3 doses of vaccine subcutaneously at 2-day intervals in the following amounts: 0.1 ml, 0.5 ml, and 0.5 ml. Rabies in man has decreased in recent years to the point that only 6 cases have been reported since 1961. After exposure to rabies, patients with bites about the trunk or extremities with no extensive tissue damage should be given rabies vaccine in 0.5 ml doses subcutaneously daily for 14 days. In cases of extensive tissue damage, multiple bites, injuries about the head, or where treatment has been delayed, 2 0.5 ml doses should be given daily for the next 7 days. Anti-rabies serum is a useful adjunct to therapy with rabies vaccine for the prevention of rabies, but should not be used as a substitute for the vaccine. It is of vital importance that the dog be caught. If it dies after showing signs of rabies, its brain should be examined for the presence of Negri bodies or fluorescent antibodies. Cholera, an important disease in the United States until 1893, is now confined to Southeastern Asia, China, and the Near East. A killed vaccine is available for people entering endemic zones, but the immunity conferred thereby is of relatively short duration. Immunization is obtained in adults with a 0.5 ml injection of inactivated cholera vaccine subcutaneously, followed a week later by an injection of 1 ml. For children under 11, the following doses are recommended. Booster injections of from 0.1 ml to 1 ml, according to age, may be required every 6 months. Plague occurs in wild rodents and/or in man in many parts of the world. In the United States, the endemicity in wild rodents is slowly moving eastward. Human cases are rare, about 500 cases having been reported since 1900. This is a bubo showing extensive necrosis and bubo pasturella pestis in large numbers. Plague immunization may be obtained in adults with a 0.5 ml injection of plague vaccine subcutaneously, followed by 1 ml given 7 to 28 days later. For children under 11, 3 subcutaneous injections at 7 to 10 day intervals should be given as shown. Reimmunization may be required not more often than every 4 to 6 months where plague is a hazard. Basic typhus immunization may be obtained in adults by a 1 ml subcutaneous injection of typhus vaccine, followed by a second injection of 1 ml given in 1 to 3 weeks, and a third in the same amount a year later. Children under 11 should be given equal doses of vaccine 1 to 3 weeks apart. The dose for a 6-month-old child to a 2-year-old should be 0.1 ml. 3 to 6 years, 0.25 ml. 7 to 10 years, 0.5 ml. Boosters of from 0.12 ml to 1 ml according to age should be given annually to retain immunity. This is the reported distribution of human cases of yellow fever. Cases in jungle animals are important because they may, under certain circumstances, feed urban epidemics among man. Immunization for all age groups is obtained by a single subcutaneous injection of 0.5 ml of a 1 to 10 dilution of concentrated yellow fever vaccine. Containing an attenuated strain of virus, a similar dose as a booster may be required every 6 years. These are intranuclear inclusion bodies in liver cells. The administration of an injection for immunization against an infectious disease is a simple procedure. But to avoid infecting the patient, it is essential that a sepsis be maintained at all times. Store vaccines and serum products under refrigeration. Reconstitute live attenuated vaccines just prior to use. Rubber stoppers of the antigen containers must be disinfected. The physician should be familiar with recent medical literature and with package literature before administering any biological product, and every precaution must be taken for the prevention and arrest of untoward reactions. Serum therapy should be employed only when definitely indicated and only when the physician is equipped adequately to combat such reactions as may occur.